I just want to welcome all of you tonight and thank all of our participants for signing up and all of our attendees for coming out to support participants. It's really great to have an event on campus that is bringing together different schools. One of the topics that came up at one of the recent President's Fireside Chats was the fact that there isn't enough inter-school activity. And I suppose this counts as one. So I'd like to welcome our participants from Mailman, from the School of Nursing, from the, from the med school, and of course from SIPA, and from my home school, the School of General and Continuing Education, the Master of Science in Sustainability Management program. So tonight would not have been possible without the involvement of all of the entire board of SUMA Net Impact. Net Impact is an organization that looks to drive change professionally at each level of your professional development. So the on-campus chapter here at Columbia, we've been focused in the SUMA program in trying to get a lot of different speakers out from a vast variety of areas. We've had speakers from the Sustainability Accounting Standards Board, SASB. We've had smaller dinners with representative from Morgan Stanley's Global Sustainable Finance Group. And we've done a number of professional development events. And tonight we're really pleased to be hosting the Hult Prize competition. And this year, as you know, the topic is non-communicable diseases in urban slums. And we're really interested in the topic of non-communicable diseases since it forms part of the larger sustainability problem. And I just want to welcome here tonight to speak to a little bit about sustainability and how that plays into the role, Professor Pat Kinney.
Hi, everyone. I'm from the Mailman School of Public Health. I'm glad to hear that there's others that are part of the competition here from the school, and it's very exciting to be part of this. Others, I saw a hand raised in the back. I look forward to meeting you after. So Lisa gave me a hard challenge, which was in 3 minutes to tie sustainable development to the Hult Prize that you guys are working on. But it's actually not such a big reach. The hard part would be 3 minutes since I've already used one, just saying what I've said so far. But urbanization is certainly a major feature of our global development right now, resulting in great economic opportunities for many people in developing countries, but at the same time bringing all sorts of challenges from an environmental and from a health point of view. Changing lifestyles, changing diets, greater access to high-calorie diets, less opportunities for exercise, more exposure to urban air pollution, more emissions of greenhouse gases from increased energy consumption is another thing that's happening with urbanization. But slum dwellers in particular are an interesting little niche in this problem, very characteristic of fast developing cities in developing countries like in Africa and other parts, and in parts of Asia. But slum dwellers are potentially going to capture some of the economic benefits that come from being in an urban area, but at the same time they're facing the most extreme environmental problems as well as lack of resources, and particularly lack of medical resources and access to medicines that could help alleviate some of the environmental and lifestyle-related chronic diseases that they face. So I'm really looking forward to hearing what you guys are proposing, and let's get on with it. Thank you.
Sorry. Welcoming Diane Healer.
Dance. It's universal. It's part of every culture on the planet. Anyone can do it, anywhere. All you need is a beat. Death. Cardiovascular disease is the #1 cause of chronic diseases worldwide at 37%. In India, it's 50%. Our solution? To leverage the worldwide popularity of TV dance competitions to get people active and moving and to prevent CVD. The benefits of dance as an exercise are widely documented, and studies show that 20 minutes 3 times a week improves heart health, circulation, strengthens lungs, memory, coordination, relieves stress and depression, And all of these have ripple effects across all of the non-communicable chronic diseases that we're talking about tonight. Our target audience involve children and mothers. Children, because we can teach them healthy habits that they can carry through the rest of their lives. Mothers, because they directly influence families and the communities, especially with diet. And we will launch our project, our solution, in India, where 5% of the population carry a gene mutation that makes them predisposed to heart disease. Each minute, 61 Indians drop below the poverty line, spending money on disease treatments. Our model will create a dance competition to win educational scholarships, because we know that slum residents actually pay for private school even though they have access to public education. Our program will run Saturday and Sunday for 8 consecutive weeks. We will offer a free 1-hour dance lesson with a discussion on health-related habits and lifestyle changes. We will also offer quick health checks. We will collect blood pressure and the weight of all the participants. We'll target 50 people per lesson, and scholarships will be awarded by age group. For financing, we're targeting 3 major sources of funding to sustain our enterprise: social impact bond, a mobile device application, and donations. The social impact bond, we will target institutional and private investors who want to make investments that make a social impact. We will sell our bonds to them using the money to create our programs and deliver those social impacts, garnering the attention from national governments and global health organizations who are willing to pay for these impacts. They will then pay us the money, and we will repay the bond. For the mobile device application, we will create an app that we will sell worldwide that will be a fun way for people everywhere to learn how to dance from different cultures and have enjoyment from that. For donations, we will market to diaspora communities from which they have left from the target communities that we're operating our projects in. In terms of scalability, we've made conservative estimates in our cost model. We'll use 66% of their seed money in year 1, and that will be gone by the end of year 2, by which time we will then depend on the new revenue streams from our social impact bond and other items. We will also have carryover from year to year, so we will start off each new year with some reserves from the previous year to get us started while we pull in the new revenue for that year. And for that reason, we will offer no scholarships the first year, but we will go up. If we can run parallel programs, we can have impact on 25 million people in 5 countries, but India will impact 1 million people each year at an average of 200 sites. Thank you.
Good evening. My name is Mike Amar. I'm the Vice President of Marketing and Communications for SUMA Net Impact. And at this point, we will be allowing the judges about 3 minutes to deliberate over the presentation they just viewed. Oh, sorry, yes, to ask questions to the team members.
So have you tried this idea yet, and have you put it into practice anywhere, even on a limited scale?
We have not. It's all on paper so far with our cost model and our predictions based on all the research.
Okay. And is there any experiment? I mean, you mentioned, I guess, that there's some data that shows that the amount of dance you're talking about actually has a significant health impact?
Yes, we've looked at a lot of different research from different heart organizations in the U.S. and Canada, World Health Organization, and they've shown, there are studies that are widely available that show 20 minutes of exercise 3 times a week can yield significant health improvements for people with heart conditions, and even if they're healthy already.
So in urban slums, where do you find dance places?
Very good question. It will depend on the location, and we will scout out these locations before we institute the program, and we will find what we think will be either a local, maybe a market area that's not being used at the moment, or perhaps an empty field where kids play, something like that, just an empty lot, an empty space. Or if there's a school around, we can use, we would try to work and partner with the administrators to use that location.
Okay. What's your main cost going to be?
We think the main cost will be the salaries of the teachers who we will train for the program. But there's also an annual cost for the cloud sourcing that we'll be using. We'll develop our application not only to sell for people, but we will use that for the teachers as well to collect the blood pressure and weight data, and then it will go up into the cloud host. So that's a significant cost every year.
What's your revenue model? How do you repay some of the sustainable impact bonds?
We know that the sustainable impact bonds is a relatively new mechanism, and we're not quite clear on all of the mechanisms and the way it works, I'm sorry. But we have a contact in Goldman Sachs who's implemented this program with the Rikers Island program with New York City. So I've already spoken to her once, but we have access to her to help understand how this can work and how we could potentially leverage it to our situation.
Sorry, I made the question more complicated than it should have been.
Oh.
How will the program just generate cash?
The program itself will be free to the people that are in attendance, but the bond will help us cover our costs, and then we'll generate the revenue from our phone application and from our donations.
So yeah, the idea would be we would design a phone app in addition to the social impact bonds. So the phone app would have dance lessons on it, and people not in the slums, in the wealthier areas surrounding, could purchase the phone app. We would get revenues from that, from the social impact bond, and then also from the data that we collect, making that available to different World Health Organization, that type of thing.
Have you considered sort of local sponsorship by local companies, local firms, things like that?
Absolutely. We've already targeted one particular software development firm in Pune that they're very interested in some of these social impact activities, and we are in very preliminary discussions with them to see if they'd be willing to we would buy the services for develop the software, or perhaps they might donate some of them, and they could also contribute in a way by providing water at the end of each lesson so that people have something to rehydrate with. Thank you.
Now will be the deliberation time. 1 minute for the judges to make their marks on the adjudication sheets. And if the next presenter would like to come up to prepare their slide. At this point in time, I'd like to welcome Shirley Bendak, who will be presenting for the Green Falafel team.
Yes, you heard that right. That is the Green Falafel team. Imagine you walk into your car and you turn the engine on. Your daughter taps you on the shoulder and asks you if you're forgetting something. She then proceeds to yell at you to put your seatbelt on. You fasten your seatbelt faster than if a neighborhood cop had just told you to. We would like to apply this model to the healthcare sector in urban slums. Our model will break the intergenerational cycle of chronic diseases by empowering kids to serve as our health ambassadors. So how will this work? The first step is that our improved health services van will make regular visits to a central point within a community and urban slum. It will attract kids to come to the van by providing them phone credits to be able to use. They will then receive each additional phone credit by bringing in their parents for both a checkup, a health checkup to test for chronic diseases, as well as just general education programs. The first visit will be free in order to establish a relationship of trust. In addition, with the first visit, we will open them a health savings account per family. We will then encourage them to contribute a nominal fee with each revisit. This system of an improved, supposed to be in the middle, improved health conditions program, will essentially attract people and families to revisit, and that will be needed to monitor, treat, and prevent chronic diseases. In terms of financial scalability, we believe that once we achieve a 40% participation rate within slum communities, we will be able to essentially sell data, both to governments, nonprofits, businesses, and healthcare providers, in the sense that they'll be able to understand more of a macro level of what happens in urban slums, as well as in order to be able to allocate resources and treat aid more efficiently. We have seen that the virtual healthcare market is $23 billion. This is projected to increase to $59 billion in 2018. We believe this has a market to fully break the intergenerational chronic disease impact in urban slums, and we feel that our solution will help prevent this. Thank you.
For the question and answer session, we'd like to invite the whole team to come up to the podium, if they would like to be able to answer.
So can you tell us a little bit more about which entities you think will actually buy this data? Like, going to be primarily governments?
Sure. So governments, we kind of divided it between a macro level, just understanding the layout of urban slums, a census, in a sense, that will apply more to governments. But we feel that healthcare providers, perhaps even insurance companies, and nonprofits that actually just want to allocate aid more efficiently need to understand what's really happening in these slum areas in order to actually effectively treat it, whether in a certain community the problem is more heart disease or in another area if it's more respiratory problems. So that was how we saw it kind of in a two-tier system, a macro level versus more healthcare oriented.
And have you guys looked in terms of a cost model for selling certain types of data?
We've done some investigation. It really will depend, I think, on the type of data and services they'll provide. And some of our research indicated that one of the biggest challenges not-for-profits find operating in slum areas is lack of data. So I think it will depend, looking at maybe the volume of data, how much data they're purchasing, the type of data and levels of granularity for this, and what the market would support. I think this is a relatively new concept within nonprofits, so we'll need to do some evaluation on willingness to pay.
And then how will you fund the startup and then the expansion to reach the 25 million with these, I guess, the buses and...
So the first step is really achieving scalability before we can even consider kind of long-term financial scalability. So I think the first $1 million will go towards the initial daily operations of a pilot program. That includes also the people within the van, which we believed would be a medical practitioner as well as a driver who's more familiar with the area. But there's also long-term growth potential here. For example, selling sponsorship opportunities on the van itself. You can even imagine Clinton Global Initiative driving around, or even Net Impact. So there are sponsorship opportunities as well as on the van.
Educational programs, opportunities to partner with us in developing educational programs.
The cell phone, the phone credit providers could also, maybe telecom, O2. So there are potential opportunities to help fund and reach scalability across different urban slums.
From a technology perspective, how will you collect data in such difficult environments? How would you aggregate that and then decide on what you can do with it?
Probably look at leveraging smart tablet technology, setting up easy-to-use database interfaces, and then using web-based technology, uploading that into a server system. Most slum dwellers, there's more access to cell phones than there is to clean water in the world, so most areas there is some sort of satellite or other technology infrastructure to capture and transmit data to larger server systems.
Can you tell us about the value proposition for the slum dwellers? Why would they pay the nominal fee to come back to your visits?
Sure. So through our research, what we found interesting is that slum dwellers do have a willingness to pay. And in some places, they'll actually pay for private health care services over government services because just like any consumer, they value things that have a price tag attached. Paying somehow has a perception of a higher quality. In some areas, urban slum dwellers pay between $8 to $10 for doctor's visits. And what we're looking to do is really provide, in a way, an insurance program where they do have a health savings account available to them. So they've set this money aside. So when they do have medical emergencies or need long-term treatment for chronic illnesses, they'll be able to cover the cost of diabetes medication or an inhaler for asthma, these types of services. There are programs in place that show that these individuals are willing to pay for things like life insurance or disability, and that provides great benefit to them.
Yeah, I'm sorry. Say that.
Sure.
Please join me in welcoming Bruna Santos, who will be presenting for the CU Hope Tank team.
Good evening. We are the CU Hope Tank, and we are here today to talk about the chronic disease care. What you are presented today is a new business model. It's a new way to look at the problem called Diagnosis Hub. Look at Brazil. In Brazil, there are 17 doctors for every 10,000 patients. And the doctors, when they attend the patients, they don't have enough information about them. But at the same time, there are brains and people and arms out there, and in this room, that are willing to change the situation. So how we put these people together to work, there are innovation out there, like this guy, Jack, who invented this paper strip that is able to diagnose cancer for 3 cents. There's the government, this very important actor, who is willing to change the way it delivers service to the society. And there is the private sector, who is in the 21st century is delivering more social impact and also have to invest in research and development. And there's a myriad of NGOs and social workers out there who are developing solutions, and researchers and medical students. How we put all these people together, because people in the slum still don't see the results from all this movement. Our solution is the Diagnosis Hub, where you connect the people suffering from chronic diseases to all this knowledge, capital, and technology in a win-win cooperation model. So imagine if we have randomized hubs all over the slum, doing diagnosis with these kinds of technologies, collecting data at the same time, collecting data which is going to be stored in a cloud. This data is not only going to be stored in a cloud, but also analyzed by researchers. And this data can serve to create a physical and an online environment where companies, government, NGOs, and researchers, and also the private sector can all work together to deliver better service for the slum. In the past century, we had the randomized experiments which changed the way we deliver service in public health. And in this century, we have big data, we have cloud computing, and we have a new way of doing business, which is called public-private partnerships. How we put all these things together to deliver better service for slums. This is the Diagnosis Hub. Thank you. My group, please.
We'll ask the group to please speak into the mic for the Q&A session.
Okay.
So you've sketched a nice concept of bringing people who are suffering from chronic diseases in contact with this knowledge that's growing. But how would that connection actually occur? How do you
Our idea is, imagine, for example, Vidigal favela in Brazil. I'm sorry, I just screwed it up. Imagine Vidigal favela in Brazil, for example. And then you randomize hubs, which is in these hubs, diagnosis hubs, they're gonna use those technologies that people are developing, like the paper strip that diagnoses cancer, or the smartphone that can diagnose diabetes. And using the people we're going to take advantage of the diagnosis, and with this data is going to be uploaded in the cloud, where it's going to create an environment for people integrate this data, analyze this data, and develop solutions. So it leaves room not only for the diagnosis, but also for the government in partnership with companies develop solutions. Because what we realized looking at all these ideas is that, of course, the problem is not the lack of good idea, but how we manage to put all of them together and bring them to the people in the slum that still don't see the solutions.
We connect several technology providers, and they actually respond us with a very positive attitude and say, if you want to do this, we can provide you with a high discount rate, or we can provide you even for free for charity. So this is kind of like they're willing to do that. Yeah.
So in terms of financing, if we break it up, the financing into creating revenues and also the expenses, on the expenses front, we can cut down expenses dramatically by having the discount rate, and also on the revenue front, because we're partnering with the universities, that we might be able to co-sharing some of the funding for the research, and also for the private sector, like for the medical equipment cooperation, they are also motivated to gain access to this data, which is a value added to the R&D research. And also, like nowadays, the public sector is investing so much in this, creating this open source data network.
Let me just ask, amongst the participants, the players here, who do you think of as the customer? Is it the patient, the doctor, the hospital, the labs, the universities?
Okay, yeah, that's a very good question because we thought of that in many times, but it's hard to say because, as I said, it's probably going to be a win-win cooperation because, of course, the patient in the other side is going to be benefited for a better medical service, but also the private sector and the government is going to be collecting a huge amount of data and processing this, and we know that for chronic disease, this is really important to detect what are the factors influencing. So it's hard to say, but I would say that people who are going to use this data is probably going to be the main customers because they're going to have like a long-term outcome more than the people in the slums. But it's hard to say. As I said, it's a win-win model in our point of view.
You're talking about integrating many different types of platforms in terms of data, and it's sort of in a way a platform you're offering. You're trying to give these people access to these platforms. How are you going to centralize stuff, and how's that connection going to occur on a tech level?
Do you mean the way that the data is being collected?
Yeah, I mean you're going to collect data from many different sources that don't necessarily integrate, and so are you going to have your own applications or? We're
gonna use the applications that are already being developed by like the things that I mentioned. But we're also going to have what we call the headquarters, which is going to be either online and physical to create this environment where we can randomize and cross and integrate all this data to analyze. Okay, thank you.
Presenting for the Link to Health team, Mark Mariano de Guzman.
New research is showing that many first-world, non-communicable diseases have reached epidemic proportions in developing countries, and they have begun to strain the healthcare system beyond what they can handle. As graduate students from Columbia School of Nursing, we would like to present a simple, flexible, and reproducible solution to help manage the epidemic. For our case study, we've decided to focus on the diabetes on the urban slums of Cambodia. Now, for diabetes, there have been 382 million worldwide who are affected with it. 60% have been estimated to be in Asia. And in the city of Phnom Penh, Cambodia, 212,000 are afflicted, with 134,000 undiagnosed. This is due to the lack of resources, expertise, services, logistics, and data to support their management of chronic disease. Community health workers, micro-clinics, mobile clinics, and NGOs have to fill the role of primary care providers when symptoms have already highly progressed. Now, our solution is to develop software linked to health that will enable community health workers, primary care providers, and health ministries to systematically assess, collect, and manage secure data to treat and educate patients in their respective communities. Now, using this SMX technology, community health workers can go through an easy-to-follow assessment tool and screen for diabetes, as well as educating community members on risk factors. Now, health workers are able to go door-to-door, and they can assess patients while entering information such as the urine strip analysis, blood glucose, blood pressure, medication management, their occupation, and their family history. Now, this tool will allow community health workers, clinics, hospitals to case manage and rapidly communicate core referral info to one another. And the data will be stored to HIPAA compliancy, where the general transparent data will enable ministries to efficiently allocate resources. Now, this software will not only help diabetes, but it will serve as the building blocks to combat and manage other chronic diseases such as hypertension and hyperlipidemia. We will build partnerships with Cambodia's Ministry of Health Technical Working Group to reach out to not only public, but private and NGOs to collaborate in care. In 1 year, we expect this software to be implemented in 20 public clinics in the city of Phnom Penh. And through 5 years, we expect this software to be implemented in various developing countries in Southeast Asia, as well as incorporating educational institutions such as the School of Nursing to use the software in their training, as well as train and recruit future global citizens. With bringing early screenings to the urban slums, we can begin to change the culture of chronic disease management. Thank you.
So, could you explain something about where the revenue comes from?
Take this one.
Could you repeat?
Yeah, so what's the basic business model? Where's your revenue coming from in this?
So our product would be the software,
right,
which we would sell to major clinics, or NGOs, as well as hospitals and education institutions. So this allows them to centralize and standardize their data that they receive.
So you're a software provider, basically?
Correct. With the extension, with the SMS technology extension.
And have you guys looked into public policy implications for aggregating such data?
Yes, for Cambodia, we've looked at the policy and what they're looking at in terms of reducing the NCD cases. In terms of public policy, and I'm sorry, what was your question?
Or just legislation that you would have to get necessarily passed to store this type of data?
There's certainly no policy because there's a lot of NGOs that are working right now with trying to get data and assisting with gathering that data for the government, but there's no standardized information for the private clinics, the public clinics. So essentially, there's just scattered information that hasn't been stored.
Let me just ask a follow-up question. If you think of yourself as a software provider, what is it that's so special about the developing world or Cambodia? Why not use the same kind of management tools that are already available elsewhere?
Certainly, it's replicable for across industries. With this technology, it's facilitating community health workers, people on the ground, because oftentimes in developing countries, the healthcare model is unique in that you're going out door to door and getting people screened. And so this is more of an efficient, transparent way of getting that information back to hospitals and ministries of health, as well as the government, so they can allocate the resources, and also private companies who would probably want this information to allocate their resources. I know Novo Nordisk has a program, a mobile clinic, as we mentioned earlier, in Cambodia, where they can offer $5 of medications for a month to people in Cambodia, in rural communities. But they don't have the information about all various communities in Cambodia, urban, rural settings. So I think this is definitely something that they can utilize.
Just following up on an earlier question, if there is no legislation around this data, obviously financial and health data is probably some of the most sensitive data that you can have. What are you going to do in terms of best practice and sort of on the ethical side to protect people's sort of vital data?
As we mentioned, there's HIPAA secured encrypted information, and I understand the sensitivity when you're walking around with a cell phone and collecting information on patients. If we can encrypt that, we can definitely encrypt that and give it to clinics and refer folks as necessary. So there's definitely consent and necessary information that we can provide patients.
Please join me in welcoming Laura Sundblad for Team Power Up.
Good evening, everyone. My name is Laura Sundblad, and this is my partner, Allison Lee. We're here to present Power Up, which is an innovative social enterprise that unleashes the power of play. The core principle of Power Up is that preventing non-communicable diseases starts in childhood, and it starts with play. Every child needs safe and accessible areas where they can engage in physical activity, social interaction, and where they can go with their parents to find key information that will help them live healthy lifestyles and access services that they need.
So, Power Up targets children in slums who are at risk of non-communicable diseases, specifically cardiovascular disease, diabetes, and mental illness. It targets children before they enter the cycle of NCD by providing safe community play spaces. It focuses on the Southern African region, and we intend to pilot in Zimbabwe first. Safe play spaces are critical to healthy child development and disease prevention, but there is a lack of finance for this kind of infrastructure. So Power Up's model pairs a for-profit entity with a non-profit entity. The private model is a gym catering to high-income clientele in the city. The gym provides the revenue to support the nonprofit activities while encouraging healthy lifestyles for its customers. The nonprofit model engages communities to imagine and construct play spaces that are relevant to their lifestyles. It provides health awareness, and it facilitates partnerships with service providers to improve access to medical services, such as early screenings. We decided to separate the for-profit and nonprofit pieces in this way because accessible play is very central to our mission, and we did not want revenue generation to interfere with that goal. Basing revenue generation in a more stable business environment mitigates the risk, and the model harnesses resources within the country.
So in our first year of operation, Power Up will launch our first gym in the Harare Central Business District. We believe that ensuring revenue generation first is the more responsible and sustainable way of engaging in a country. So we'll use part of the Hult Prize to leverage additional investment for the private part of our model. We'll then pilot our playgrounds in 3 slum areas near Harare, and during the first year, we'll be engaging in a learning process to collect data, test our assumptions, assess demand, and also to scout new markets within Zimbabwe and beyond. Within 5 years, through aggressive expansion in the Southern Africa region, we'll be reaching 25 million slum dwellers. We target in particular cities with high income inequalities and high growth rates, and the Southern Africa region is indicative of these characteristics. For example, in Angola, Luanda, and in Mozambique, Maputo offer great areas for growth. By targeting these areas with high proportions of young people and constantly increasing populations, we can maximize our impact. So thank you, and we look forward to your questions.
You presumably be competing with existing gyms in these places, right? There are other existing gyms out there.
Yes.
So have you thought about why you will be able to take business from them? I mean, is that a serious issue for you?
From my personal experience living in Harare, there are not very many high-quality gyms, and I also think they are missing a large portion of the market, which is the travelers and NGO workers who often stay at the hotels in the city, but they don't have options to use these facilities.
How will you make money, and how will that be tied to your impact activities? So I assume you'll have some gym membership or fees for classes or sessions, but how will that then get used for other activities?
So in the gym will be located in a higher income area and targeted very much at the high income end. And so the margins there will be strong. We're modeling off of New York boutique, exclusive, making health and wellness an aspirational goal. And so then from those margins, we can subsidize the activities that are in the more informal areas. And by getting the revenue from places where we can have a secure rent contract, secure land tenure, that helps us then mitigate the risk in the nonprofit areas. So the nonprofit area is a more traditional set of, we obtain essentially grant funding from our gym and relocate it to the informal settlements.
How much does each gym cost, and how many do you need to get to 25 million people impacted?
That's a great question. We imagine that our largest cost will be for the first gym in Harare, and we imagine that to support at least 3 play centers in the surrounding low-income areas. But we're going to have to look at that model carefully to see if that's feasible as we go forward.
Do you have any way to measure the effectiveness of this program in terms of reducing NCD incidence in your population?
Yeah, so preventive care is always harder to measure than actual treatment. So we will have to measure it through proxies such as people, children and their parents coming to the play centers. We'll also have an engagement before the play center is in place with children engaging in the process of actually planning the gym, and through that getting awareness and education. Sorry. Yes. But It is. We'll have to look carefully at of how preventive health impacts have been measured in other comparable enterprises. Thank you.
Presenting for Team MZIMA, Matt Smith.
Thank you. My name is Matt Smith. I'm a first-year MPA development practice student at SIPA. Prior to coming to SIPA, I worked in East Africa, specifically some of Nairobi's slums in Kawangware and Mathare. And what I learned was that there's no panacea to tackling community health issues. And instead, each solution needs to come in an integrated fashion. Zima is a Kiswahili word meaning full or whole or healthy. And it's in that meaning that we've designed Zima to integrate 4 already proven methods and innovations in order to tackle non-communicable diseases in urban slums. So how does this work? Zima uses, it gets to clients through a decentralized pipeline of community health workers that are girls, ages 16 to 24. And they go and visit houses door to door and walk clients through preventative health checkups. And in doing this, they're using a mobile health platform that walks them through questions on that are indicative of non-communicable diseases and also conducts non-intrusive health checkups. After time, this data is accumulated and it creates a longitudinal, basically longitudinal chain of data that's able to create health reports for users, which they receive on their mobile devices, but it also informs a lean supply chain. So users have the option to either buy medication from other dealers, or they can guarantee cheap and also authentic medication through the Zima supply chain, which uses the data from the mobile health networks to be predictive and can run lean, and it can gain cost efficiencies through that predictive model. Finally, after potentially a year of working in communities and building up longitudinal health data, Zima is able to break down many of the barriers that microinsurance providers face when providing services to urban slum dwellers, which is basically uncertainty and risk. So Zima adds value to urban slum dwellers in 4 ways. It's accessible. Community health workers are going door to door. By using girls, we're able to better interact with the gatekeepers to families, which tend to be women. So it's instilling trust. By being able to send health reports to clients' cell phones after they go through a Zima session, they're informed on their symptoms, the risks for disease, as well as the medications that are recommended. In the short term, it saves these clients, saves them money in the short term by providing a bit more information. So it's through the medication that they're saving and buying from Zima clients, which is cheaper. Also through avoided health costs on, say, traditional medication, and then also in the long term through microinsurance provision, which can save them money over the course of their families. Thank you.
So you are employing the community health workers.
That's right.
And you're also providing the mobile devices on which they're collecting data.
That's right.
And you're managing that data.
That's right.
And so what are your revenue sources there, if any?
So, right. So the main revenue sources actually would be, at first, sale of medication to these clients. And in the long term, it'd be providing microinsurance to clients in urban slums.
So you'd act as an insurance broker, essentially?
You would. And by providing, and potentially you'd be also, you'd be using lower risk pools to subsidize higher risk pools. And through this longitudinal health data that you're able to provide from door-to-door checkups, is you are actually breaking down a lot of the uncertainty that microinsurance providers have had trouble with in providing this in the past.
How do you get, what's the value proposition for everyone to come in at the beginning? You're going door to door.
Sure.
Why would you not expect to get the unhealthy families signing up versus the healthy families?
Sure. So I think that the health insurance, like I said, would probably come later on after we've worked in a community for a while and better understand which types of services to be provided. By basically coming in and initially providing this health service as checkups, we can run models by doing it for a fee, also for free. And that would help better inform the types of products we design, their costs, and then also recognizing like how we can subsidize higher risk pools, again, with the revenue that's collected from lower risk pools.
Sorry, and the advantage in terms of existing insurers is that you have more data and that you have a sort of a better opinion of who these people are?
Right. So you basically have their health insurance, or rather, excuse me, you'd have their health data over a longitudinal period of time. You also would have their buying habits as well. So if they're purchasing medication from you, is you can also better understand the risk and how they're treating disease and how they'll fall into a risk pool. Of course, confidentiality issues come up with this, but if you have principles of encrypting data and also retaining earnings and subsidizing higher risk pools, then you don't have those incentives for exploitative behavior.
Do you have a sense of the margins on the local medicine that'll allow you to essentially build up this database over the first couple of years?
Sure. So there's an existing program called Living Goods, which does something similar. They deploy people in like an Avon Lady style sales network. And what they do is they sell like water filters and bed nets. They also sell some medications. They found that these markets are profitable. We recognize that if we're able to use this platform, over time we'll be able to be predictive, and we can better understand exactly what the demands will be from retained customers as well as new ones. So we'll be saving money basically by avoiding overstocks and things like that. So we can run a just-in-time, lean supply chain. Okay, thanks.
Please join me in welcoming Shriram Gupta for Team Swastika.
Good evening, everyone. For those of you who don't know, Swasthya means health in Hindi, which is the national language of India. I think some of my friends have already covered what some of the biggest challenges are given the non-communicable disease in urban slums. Given our background of working for over 15 years across India, Pakistan, Bangladesh, in healthcare, in slum upgradation, in microfinance, what you realize as one of the biggest challenges is basically the access to doctors. So the challenge that exists here is that since the urban economy is a monetized economy, unlike the rural economy, there is little scope to get service without paying cash. What happens as a reason is that even the authorized slums or the legal slums in these countries have to access healthcare. To access healthcare, have to travel large distances. What this means is that since these people are casual laborers, there is a humongous opportunity cost of losing the daily wage. The second problem is that since they have to travel and they have to wait in long lines to access healthcare, they tend to avoid going to the doctor till the disease comes to a stage where it's very late. So what our solution does is to leverage community health workers or women health workers in these urban slums, train them on basic medication. So if you look at the value chain of a disease from prevention to diagnosis to treatment to management, each disease basically, there's scope for these women to be trained, even though they may not be medically knowledgeable. So our model basically leverages that, trains these women, and then provides healthcare to people in the urban slums. The way we do this is to tie up with existing microfinance institutions and provide a health kit to these women, which the microfinance gives them a loan for, and then train them and then basically replenish their stock once that gets over. We hope to start this first in India, given that the healthcare, the urban healthcare is, if I can say, in shambles compared to even the rural healthcare, and microfinance is fairly well established across the country. So we would basically like to leverage that and start a pilot in Uttar Pradesh, which is the largest state in India and has a very poor health record. Our hope is that with the seed money of $1 million, we could basically access 30,000 health kits and spread across 3 states in India to start with over the next 5 years. Over the next 5 years, we'd like to expand to 6 other countries and serve 38 million people. Thank you.
Could you say more about the type of training that you provide for these people, and what level of training is needed to do this safely and reliably?
Sure. So these are usually women who are literate, may not be educated to a large extent, but then they basically undergo training like checking BP, basically providing insulin in case of diabetes, and other things. Now, this has worked in other countries. For example, BRAC does this in Bangladesh and several other countries, but it's more rural focused and more communicable diseases focused than the non-communicable. And also, it's not a profitable model because they do this under their NGO. So this has been done in the past. Yeah. Also, the document that I left on your tables talks about various diseases and the type of training that needs to be given.
On a similar topic, I'm wondering how these trained field workers will be equipped to diagnose chronic diseases. I can understand that once the chronic disease exists, that they could know perhaps what medicines to provide. But how do we figure out what the chronic disease is that they need to treat in the first place? That seems like more of a medical kind of decision.
Yeah. So let me give an example. So in case of hypertension, it's a fairly systematic way in the way they diagnose this is to basically check the blood pressure of a person on 3 different occasions under dissimilar situations, and then see if you see that the blood pressure in all these 3 situations is higher than a certain number, you can basically diagnose that this person has hypertension.
So your role is to train people and then manage the whole process? Is that the role of the organization?
So it starts from training people, building partnerships with microfinance institutions, with drug manufacturers, pharmaceutical companies, and then basically, scaling the program. Yeah. The other thing we also would like to do, and that is after we reach a certain scale, is to leverage the network that we already have to basically sell other products, specifically around solar power, specifically around clean water.
The way it seems to me, your key partners here are the pharmaceutical companies, and in some sense, it's a way to bypass the doctor, right? You're selling the pharmaceutical product and lending money to the community health worker to generate a market for that pharmaceutical product. The piece that you're leaving out is the discretion and the professional judgment, and this would obviously be a disastrous liability model in any developed world. What makes you think that in a developing world where there might not be malpractice issues, but nevertheless, if there are problems with it, there'll be literally heads rolling.
Right.
How would you deal with, how are you going to address that problem?
Sure. What we perceive we'll do is that when we target each country, let's say we start with India, we identify the diseases that are more prevalent, but within these diseases, only places or only parts of the disease along the value chain where we can, with reasonable confidence, predict a certain outcome. Having said that, the goal of this is not to bypass the doctor. The goal is to provide healthcare to places where there is no doctor. But we'll have a very strong referral system where at any point, if we see that this isn't working, we immediately refer them to the doctor. So we understand that as a challenge. Yes.
I'd like to welcome for Team Listen, Karen Rubanovich.
Listen, in 2012, over 130,000 suicides were reported in India. And since 2004, 1 in 3 suicides were committed by adolescents and young adults. Yet suicide is not talked about and often stigmatized. On average, there's 1 psychiatrist for every 300,000 people in India. And in urban slums, access to mental health professionals is even more scarce. How can we address the problems surrounding mental illness? Using rates of suicide as an indicator of an underlying problem, we propose an idea to develop a 6-week narrative medicine educational curriculum for adolescents that addresses the lived experience of mental illness in urban slums in Chennai. Our curriculum uses an interdisciplinary approach to address suffering and illness with methods from anthropology, psychology, oral history, literature, and philosophy. Narrative medicine recognizes that a scientifically competent medicine alone cannot help a person grapple with suffering and the loss of health. Our curriculum would teach skills of close reading of text, reflective writing, empathic listening, and self-reflection in order to better understand and create awareness of the complex issues surrounding mental health. The prize money would go towards developing a curriculum tailored towards adolescents in school settings. Suicide is a complex issue requiring a creative, multifaceted approach, which our narrative medicine curriculum can provide. Next to me is a slide summarizing our one-year plan. We have broken down our plan into realistic and pragmatic objectives. The end product of our one-year plan is to create a free online narrative medicine course and curriculum that could be accessed over the internet around the world. Our idea is sustainable because the prize money would fund the development of a free educational curriculum that would be distributed and maintained online. Our idea does not require other technologies, and since India mandated free education for children up to the age of 14, we would use the expanding infrastructure to house our curriculum. In 5 years, we would like to expand the teaching of our curriculum to all schools in other major cities in India. Our long-term health-oriented goals include to decrease rates of suicide amongst teens, increase awareness of mental health in schools, increase access to mental health resources where available, and decrease the alienation that mental illness places on individuals. And our education-oriented goals include to increase literacy and reading comprehension and improve writing skills. The narrative medicine method is adaptable to using cross-cultural frameworks. The structure of the curriculum is flexible and could be used to address other chronic illnesses. Let this be the beginning of a new kind of global narrative. Thank you for listening.
Just a question. I guess probably more than half of the people you're trying to serve are illiterate. So when you say close reading of texts, is that for the people you're serving or the teachers or somebody else?
Well, a close reading of text is just one example of a type of activity we could do with these kids. The wonderful thing about narrative medicine is that everyone has a story or a narrative to say. And so a lot of this can come from the oral tradition of storytelling in that specific location or that area of the world. So reading a text is just one example. It could go as far as reciting poetry or reciting a traditional psalm or singing, responding to a piece of artwork, showing a student artwork and having them respond and see what it evokes in them. So it's just one example.
Can you walk us through your revenue model?
So as I mentioned multiple times, the actual curriculum itself would be free, but that would just be for the suicide prevention model. The narrative medicine program has shown efficacy and has been published in a number of different journals, including JAMA, New England Journal of Medicine, and The Lancet, and we know that it has positive results. And because of that, and it can be tailored to other chronic illnesses, how great would it be for other NGOs or other organizations to actually want to have a curriculum like this put in every single school in India? So if we can have other organizations that deal with different chronic illnesses like heart disease or diabetes, they could pay us, they would invest us with the money, and we could create a curriculum specifically for that health initiative. So while this first suicide curriculum or mental health curriculum might be free, but even though it's online, we could have commercial breaks between the different videos where any sort of suicide prevention hotline or organization could easily advertise their resources for the viewers.
What measures would you be able to enact in order to ensure wide use of the curriculum?
Basically,
as far as what measures to reach out to other people and have this gain some sort of momentum in that respect?
Well, yeah, I guess it looks like a potentially very effective curriculum to train people about chronic diseases, including mental diseases. But if it just sits on a computer and it's not used, it's not actually going to reach too many people.
Right. So our plan was to use the infrastructure of India's expanding educational system, and we would start because as of 2010, everyone is now from the ages of 6 to 14 has available schooling. Free and mandated schooling in India. So what we would do is go into and use that infrastructure that's already in place and growing to reach out, and then hopefully eventually we'd be able to reach out to the health system in general.
Furthermore, with the curriculum being online as it is, there are ways to track the number of times it's accessed, the number of times it's downloaded, and so we could also, sort of mandate that people upload their information, just give us a measure of when they feedback when they use it, and let us know that they have done so.
Thank you guys very much.
For our final presentation, Mariam Savabi for Mosaic Project.
Hello, my name is Mariam Savabi, and I, along with Preeti Rao, are both physicians who are pursuing our public health degrees at the Mailman School of Public Health. We'd like to bring to you the Mosaic Project, which is a combination of our clinical experience working with patients with chronic disease and also working in low-income settings. Here is our patient. This beautiful young lady will go to the store. We made sure that we made our intervention that was patient-centered. We wanted to make sure our intervention came to the patient and was easily accessible and also affordable. So here she is. She's going to go to the store, buy some food for her family, and while there, because she has diabetes or hypertension, or maybe she just wants a screening, she'll have the opportunity to get a glucometer screening or a blood pressure screening. She'll have this done by a trained healthcare worker who we will train, and she will be able to take the results of this information and also the patient information and send it to our data collection center, which is a Mosaic Project. We'll use data compiling software in order to follow trends of our patient and make sure that we don't see anything that's alarming that's coming up for our patient, and also to spread information to our patient about their disease process and also what we would recommend for them as far as healthcare. We would share this either via text or phone calls to our patient and also to her family if she so chooses. This would increase her literacy about her own education, increase her empowerment, and also the ability for her to manage her disease, and also give her the opportunity to have access to physicians. If we felt that she needed to have a physician visit because we didn't think her diabetes or hypertension was managed very well, we would send her to a physician. And we would do this by having a micro insurance scheme that we've created where she would pay us about 10 to 15 cents every single month, transferring phone credits to our organization. We would then be able to contract with local physicians and build up the local healthcare workforce by contracting with physicians, managing our prices, and also making sure that we share information both with these physicians and also they can share that information with us. We'll pay rent to our storefront that we'll be working in, and we also will pay a salary to our healthcare workers. We also would have our healthcare workers to increasingly expand their knowledge level so that we would be able to expand our services that we provide to our patients in the future. And she would also be a wonderful resource to her patients if they ever had any questions because she is easily accessible. We would work with telecom. We would have a collaborative relationship. Since we are using a mobile phone network and we understand there's about a 70% penetration of mobile network usage within slum settings, it would be a wonderful medium for us to work with our healthcare worker as well as our patient. We also would work with pharmaceutical companies. Pharmaceuticals are very interested in working with real-world data, which we would be able to provide based on the data that we're compiling from our patients and show them trends and information about what is happening within these different settings. We believe that our model is reproducible. It's also very expandable, and we imagine that we would be able to spread our services that we provide, such as asthma action plan, pulmonary function tests, for example. We also believe that it's very mobile. It can be used in anywhere, and it's also culturally competent. We believe that our intervention empowers our patient to take care of themselves, to manage their own health care, and also to have a wonderful, healthy life. So not only can she take care of herself, but also her family. Thank you.
Can you explain how you generate revenue in this? You're selling the drugs? Is that part of it, or what?
No, we won't be selling drugs. We have several different sources of revenue. One of them is a microinsurance plan, which we plan to roll out in 3 phases. Our first phase will be mandatory for our participants, and the second phase we will broaden our services and broaden our options to cover the cost of drugs that are prescribed by their physicians. The third and final phase will further expand our options and the benefits that are available for our patients to cover the long-term complications of some of these diseases, to cover the cost of chemotherapy, to cover the cost of surgeries,
Again, that will be rolled out in 3 phases. And as far as buy-in from telecom and pharmaceutical companies, we anticipate those to be major sources of revenue for us too, and this model is very sustainable. Pharmaceutical companies currently are looking for big data. They're looking for real-world data, and there's a big dearth of information, particularly in slum settings. We're going to fill that gap.
How many of these health worker storefront operations will be needed to cover X number of people in the slum population?
That depends, I think, on the size of the slum. We anticipate that for every slum, depending on the size, it'll cost us between $5,000 to $10,000 for each startup, and that each healthcare worker will be able to reach between 100 to 300 patients.
Can you tell us a bit about the training of the healthcare workers?
Absolutely. So our healthcare workers, since we're using this mobile network platform, we would train them first having one interaction physically together to train them how to use the instruments. Also collaborating with the local community. We believe it's very important to have local stakeholders and community members that are working within the healthcare field so that we can have them as a source of contact and possibly further trainers. So we would have this resource, this initial time that we would train our healthcare worker, and then we would further their knowledge by having modules that would be listened to on the phone, and also exams that they would have to answer with text messages.
Also, we would first, our pilot model is to cover blood glucose and hypertension, so blood pressure readings on a daily basis. And there's a lot of data that shows that chronic disease, if you manage it properly, if you keep your blood glucose within an optimal number and your blood pressure readings at an optimal level, it decreases the mortality rates, it decreases the further complications of these diseases. And we plan to further train our health workers to take BMI, to develop asthma action plans in conjunction with patients' physicians, and to run mini mental status exams, which are measures of cognitive decline, to run Beck depression screenings.
Do you have a sense of some of those diseases or problems, whether they are more likely or less likely in a slum environment? I mean, you don't see a lot of BMI issues in slums in India. You see them amongst the middle class, right? And people with asthma mostly just die out very early. So
well, that would be part of our intervention.
I know you're trying to prevent that, but I'm just wondering, is there some way to pick diseases that are more likely to hit that segment? We may not know what those are.
Right. We've tried to find information about the exact numbers, and it's very difficult to come by, which would be another wonderful thing that our particular intervention can provide is actual data about these different slum settings. But for us, we understand that diabetes and hypertension is a very common problem, and that's found throughout the entire human race. It doesn't matter where you live. Additionally, we understand that asthma and also COPD, in particular for older adults, is a very common problem. So lung function tests or pulmonary function tests would be a very easy test for us to do, and also to evaluate the status of our patient. So that often happens with open cook stoves inside of housing, so maybe it may not be due to smoking like it would be in our country. It is due to exposures within that are unique to slum settings. Thank you.
Okay, thank you. At this time, our judges are going to start their deliberation process. First, they're going to bring 3 teams back up, one by one, and ask you any additional questions that they have for you, which will help them deliberate and decide on tonight's winner. And just to kind of keep everyone abreast of what's going to happen after that, what we're going to do is we're going to bring each of the teams back up to introduce yourselves and just tell us which school you're from and what you found intriguing about the challenge, why you decided to compete tonight. And by the time we're done with that, we should be able to announce our runners-up and our winner. Okay, the judges have selected the 3 finalists, and they're going to be asking additional questions. So could I have Health for All, the entire team up here, please?
Can you just kind of walk us through again a little bit more about how you plan to finance this, year 1 and year sort of 5? I know you talked about social impact bonds and sort of nonprofit capital and sort of a diverse capital stack, but to grow this and make it financially sustainable over time. How do you foresee that happening?
Yeah, sure. So the first year, well, we could show you our financial model, but the first year, basically, we used the $1 million fund. And during that time, we allocated some of that $1 million towards development of this app. And the point of the app is it's sort of like an exercise app, like a Nike. There's a Nike training app right now. It teaches you the moves, it times you, and the sales of that app would help towards funding years 2 through 5. The other thing that we want to do towards funding, because we don't know exactly what will happen, we wanted to kind of have backup, is the social impact bond. And again, during the first year, some of the funding would be going towards developing that social impact bond and figuring out who the partners are in the local regions who will be benefiting from the social impact and thus be willing to pay us for the impact that we're deriving. So we've got the app, the social impact bond, and then also the data that we would be gathering from the health checks at the beginning of each dance lesson. We could then use that to sell it to people who are interested in this data. We noticed that there was a lack of data about health in slums, and that is hopefully where we would take it. So we've got kind of 3 streams because we wanted to have a couple of different options.
Just have one more question on the social impact bonds. I think one of the most important things is you have to show the partners you're going to be dealing with some sort of results, and not to question, I think what you're doing is great, but how could you directly measure the impact of what you're doing in a way that would satisfy a partner on, if you look at how social impact bonds have been issued?
That's a great question. And I think the 2 things we wanted to really focus in the beginning, and so the 2 things that we'd be tracking in our health check are weight and then blood pressure, which we know are indicators for cardiovascular disease and diabetes, which were kind of the two biggest killers right now for non-communicable diseases. And since we'd be tracking those at each session during our 8 weeks, we would be able to show the impact over time. And then the idea is that over the following years, we might be able to continue these programs in the same areas where we had run them. So we would have data over the years to show the impact that we're having.
You guys mentioned that the TV dance series are very popular. How can you try to monetize that?
So we didn't mention this, but one way we thought of that is the dance app that we have, the phone app. We might be able to link with partners in the regions who are having these dance competition shows and sort of brand our app depending on the region, depending on the show in the area, and use that towards popularizing it and generating awareness. Yeah.
And we also talked about the opportunity of potentially partnering with, the people on those shows, either on the shows or judging the shows, and that perhaps maybe the winner of one of our competitions could have, a pre-recorded 13 or 30-second spot to show, maybe show a couple and then have a vote, and people could dial in or use their phones to vote for their favorite, and that could somehow be tied into donation money as well for scholarship.
Okay, we have to stop there, but thank you so much. Thank you.
Next, I'd like to invite MZIMA, Matt Smith.
So could you tell us, once you get the trust of your customers when you go door to door, what do you think is the first product you try to sell them?
I think the first product is it's the medication, and the mobile health platform was inspired by a program that's called Navi Health, which is coming out after Obamacare, which uses very statistically robust health algorithms to be able to predict risk factors. So with basically building on that, we'd be able to recommend either patient referrals or certain medications. And the hope is that we can offer authentic drugs, and we can also offer the cheaper ones. And those would be the competitive advantages. And by building up that trust, it's there at your doorstep, and you know what you need. And I think that by giving the patients the option to not have to buy them from the community health workers, it gets over the incentive of misdiagnosing drugs. Because people, for instance, if they're getting a system, they're saying you have all these things, then they might say, well, I don't have to buy from you, so I'm not going to trust your information.
Have you thought about the actual types of pharmaceutical partners you would be looking to get distribution to people, and whether or not there is adequate supply or willingness of these distributors to actually get medicines to people?
Sure. I don't think that it's an issue of supply. I think it's an issue, like, as far as the amounts. I think it's just an issue of the connections, and it's an issue of understanding exactly what the demand is. And I think if we can better show precisely what the demand is through these predictive systems. So you have partners, for instance, you have clients that have basically longitudinal health data that's built up over time. We can basically model that really well. And we can basically show that there's demand. So we could go to big suppliers, for instance, or we can go to localized suppliers. So for instance, Nairobi has lots of generic manufacturers. We can better connect with them as long as we can ensure authenticity of product, and we can get that right to market as well. Whatever's cheapest, if we're focusing on lean manufacturing, we're really focusing on the value at the end for the client. So whatever makes the most sense.
So the other group that was trying to use the community health workers.
Mosaic?
No, I think it was Swasthya.
Swasthya, yeah.
In some sense, you guys have similar models, but you're placing your faith on the predictive mobile health platform and the software and the algorithms. And they have the same model, but placing the faith on the community health worker.
Sure.
And choosing one or the other has implications for the kinds of ailments that you diagnose. How does this, having just the software, how does it limit the kinds of diseases you'll be able to address?
Sure. So we recognize with the software, it'll be able to show, say, like non-acute symptoms, for instance. Like if you're able to start to see very subtle signs and changes over time, is we'll be able to pick up on things that, for instance, regular community health workers might not pick up on, more acute symptoms. But I also think that our strength is actually focusing on the girls. Within this age group of 16 to 24, this is actually one of the things I'd worked on in some of the slums in Nairobi, was girls groups, as they show greater cohesion, especially when stratified amongst age. So girls mentor girls. And within this age group is typically where lots of people drop out of school and don't carry on secondary school because they don't have the money. And this could be basically an alternative vocational training for them. So I actually think our strength is there as well. Thanks.
And lastly, I'd like to invite Mosaic Project.
Can you tell us a bit more about who you'll be using in your storefronts, what their backgrounds will be, how you select them, what you'll do to sort of train them and equip them?
Absolutely. So we intend this model to be very, very portable, and we want to target any place in a slum that people congregate. It can be a religious center, it can be a community center, it can be a cafe, it can be a barber shop, or a hair salon. So anywhere where people can come and congregate, and then we can have our healthcare workers meet our patients there.
Who will your healthcare workers be? What will their backgrounds be? What training will they have?
Actually, it's very similar to SUMA. We would actually request that, or find young women who are in the local community who would be trained in this information. And we also have the same information as he has, that building up a women workforce, you have a lot more collaboration, it's a lot easier. And also there is opportunity in order to advance someone's education. We believe that we would like to set up a system in which they get these training modules, increase their knowledge about healthcare, and perhaps create partnerships with local universities or even some certificate programs so that they could have a career afterwards.
So the healthcare workers are recruited naively,
Correct.
sort of from the community. Oh, I see.
Correct, yes.
So you envisage these as a kind of paramedics, effectively, people without a medical training, but with some...
Right, in a way, yes. Like it would not be ambulatory, it would not be, crisis situations, but absolutely, yeah. We're taking it to our patients.
Given your cross-selling financial products or microinsurance, phone credits, and sort of consumer goods, you're obviously going to use some of the data that you're collecting, etc. What's behind the choice of text messaging versus maybe some more efficient ways to collect data and to utilize that data into your cross-selling?
Well, our idea is that we're going to have multiple slum settings throughout the world, and they're all going to be sending information to one location, one data location, and we felt that this would be the easiest way. We can't guarantee internet access every time. We can't guarantee that letters will make it. So we felt that this might be the easiest way to have that open communication continuously, both with our patients and our healthcare workers.
Tell me a little bit about the phone credits and how you expect to manage that process.
Sure. So we plan to partner with telecom companies who would then help us transfer the phone credits that our customers and that our patients pay into cash that we would then be able to use for the training and to continue our cycle.
This is very similar to something you might see in the United States, where you might, support a fund or send some money for a crisis, like such to the Red Cross, and you text a certain number, and $10 gets charged to your credit card for your phone bill. It'd be a very similar process. Thank you very much. Thank you.
Thank you.
During the judges' final deliberation, I'm going to ask each of his teams to come back up. And I just want to encourage Green Falafel, CU Hope's Hank, Link to Health, Power Up, and Swasthaya, and Listen, that the deadline for the general Hult Prize is next week. So if you've gained something here tonight from listening to your other competitors and you would still like to be considered for Hult Prize, you do have that option open to you. You will not be going directly to the regional championship, but you do have another shot at getting there. So if I could ask Health for All to come up and just introduce themselves one by one, tell us which school you're in, which department you're in, and what drew you to the prize, just in 1 minute. 1.5 minutes.
Hi, so we're Health for All. I'm Christina Wong. I'm in the Sustainability Management Master's Program. I am graduating this year, which is very exciting. Yay for everyone graduating! And I think I was drawn to this. I had a friend who competed last year and made it to the finals and just said it was a great experience. And I think it's really fun that we can have this collaboration. We're not all from the same program. And I thought it was really neat that we could work together on a big social problem. So, yeah. Congratulations to everyone for participating.
Christina's so nice. I'm Diane Heiler. I'm in the Sustainability Management. She's telling you to come over here. Sustainability Management Program. I'll graduate in May. And I think what drew me to this competition was the idea of working in some type of social entrepreneur enterprise topic, because I come from a corporate background, and this is all fairly new to me, except coming into the program. I've learned quite a bit. So this was just a lot of fun to kind of pull all the different ideas together and work on a project with a great team. Thank you.
Hi, I'm Ame Garo. I'm in Sustainability Management as well. I don't know when I'm graduating. I'm trying to drag this out as long as possible. And I wanted to participate in this because I'm from Nigeria, and so solving social issues are really important to me because obviously it's a large part of the struggle of where I come from. So.
Hi everyone, my name is Crystal Lin. I just recently graduated from the Environmental Science and Policy program. So what attracted me to working on this project was because I got the opportunity to work with a bunch of amazing individuals who are passionate about helping the community in a sustainable manner. So yeah, just like you guys.
Hi, I'm Danielle Sack. I'm also in the Sustainability Management program. I'll be graduating in May. And my reason for joining this team was to work with a great group of ladies and hopefully come up with a good idea on something preventative that can make a difference.
Don't forget, everybody, you need to dance, and it'll keep your health healthy.
Green Falafel.
I am Shirley Bendak, also doing an MS in Sustainability Management.
Hi, I'm Abhishek Bokut. I'm also from the SUMA program.
Rebecca Bishop, also from SUMA.
Marisol Rodriguez, SUMA.
So all SUMA. That was
I'm Bruna, Executive Master in Public Administration at SIPA.
Li Jing, also from SIPA, and our colleague Hando has to leave early in order to catch a bus back to the medical school. So we are the CU Hope.
Hello, everyone. My name is Limmy Heng. This is Dan Cow and Mark de Guzman. We're from the School of Nursing.
Hi, I'm Allison from SIPA. I'm a second-year student studying for Masters of International Affairs degree.
And I'm Laura Somlad, also from SIPA, also in my second year, Master of Public Administration.
My name is Matt Smith. I'm so lonely. And my team members and I actually all have econ finals tomorrow, and I kind of drew the short straw. So my other team members are Jesper Frant and Sophie Matt. We're all with the SEEP MPA DP program. I'm a first year, Sophie's a first year, and Jesper is a second year. Thanks.
Hi, my name is Sriram. I'm a first year MPA student at SIPA.
Hi, Joita Goswami, first year MPA student at SIPA.
Hi, I'm Tanzib. I'm a first year MPA student at SIPA as well.
Hi, I'm Umair, also a first year student at SIPA.
Sarvesh, first year MPA student SIPA.
Hello, I'm Karen Urbanovich, and I'm a master's student in the program of narrative medicine.
Hi, my name's Jane Zhao, and I'm also a first-year student in the Masters of Narrative Medicine program.
Hi, I'm Lindsay Wright. I'm also a first year Masters of Science in Narrative Medicine.
And I'm Daniel Eisen. I'm a fourth year at the College of Physicians and Surgeons and a first year in the Narrative Medicine Master's program.
I'm Preeti. I'm an accelerated MPH student at the Mailman School of Public Health in the Department of Population and Family Health.
And my name is Miriam Savabi. I'm also in the Mailman School of Public Health, Accelerated General Public Health. Thank you.
Okay, so the judges have finished their deliberation, and once again, I'd like to say thank you to each of the judges, and you'll be presented with a small token of our appreciation from Charlotte, who's been spearheading this event. We'll do that after, so that in the interest of time. So it gives me great pleasure to announce our runner-up tonight. And our runner-up tonight is, drum roll please, Mosaic Project. And I'm just going to ask Salahud to come up and present Mosaic Project. Well, not present them, but just give a bit on what exactly the runner-up prize entails and a little bit about what PAVE is doing.
The runner-up is going to be able to, at the time of their choice, come and work with us in our office in Soho. And we're going to show you sort of the process of raising funding on a technology platform. I'll explain what we do exactly. So I'm one of the co-founders of PAVE. PAVE is trying to be part of a sort of a slew of solutions to a big problem, which is student debt, and the fact that funding sources today are not adapted to the flexible careers and the non-traditional paths that a lot of people are following. I've actually been in your shoes. I started a non-profit sort of platform where young people could donate skills to cancer charities, and I know how difficult it is to go and ask people for money when they don't know exactly where their money is going, and I understand how important the rise of social enterprise is to being able to build these type of things. And what we do is we offer young people the chance to come to a technology platform, build a campaign, and try to raise funding from people who care about specifically what you do or the community you belong to. So the same way the internet is trying to organize information based on topics or based on people, we're trying to organize money and resources based on affinity. People come to the platform, they build a campaign and try to raise funding from people who invest in them in a way that is completely different from debt, because it's completely success based. So they're completely aligned with the people who back them, and payments under these investments are income based. And because of that alignment of incentives, it encourages collaboration and a sort of new dynamic that we think can really help non-traditional paths, and specifically the type of work that you do. So check it out. We'll be hosting having some drinks at Amigos if you have more questions, but in general, any questions, ask us whenever you want. Thank you.
And the moment you've all been waiting for, It is with great pleasure that I announce that tonight's winner of Hult Prize at Columbia, going on to the regional championship, will be Health for All. Please join me up here.
It's on condition that they dance for us.
If we could get one last round of applause for Health for All. Thank you. I invite all of you now to just join us for some mingling. We do have a representative, Alex, who's from the professional chapter of Net Impact. For those of you who are graduating and looking to transition from the student chapter into the professional chapter, you can also chat with each other if you haven't done enough of that, or with Sal some more, or some of our other judges. And lastly, I'd just like to make an announcement on the behalf of SUMASA that the end of semester party is tonight at Elmo. So once you've finished mingling, you can feel free to head down to Elmo. Thank you and have a great night, everyone. Good luck with the rest of your finals.